Hello, Working Mommy Manual listeners.
We're back at it.
This is Nicole Corning.
I'm Kathleen Wilson.
And we have a special guest today, Dr. Khoshaba, who is my personal naturopath and guru to all things health-wise, and especially around just women's issues and aging and all the fun stuff that we get to do. So welcome.
Thank you for having me. Thank you. This is so special today for a change on a Friday.
I know. I was out the past couple of days for work, and so I'm back to the office on a Friday. And it's like, is this Monday or Friday? And I was home late last night. What time zone is this?
And then halfway through the day, I'm like, and we got to go. We got to podcast. My doctor's meeting us. We got to get there. We can't keep her waiting.
I love it. At least I get a chance to sit down and beyond just the patient to patient interaction, I think that this message can reach so many women out there. And if they're struggling or haven't learned want to learn more about hormones or a particular phase in, the hormones cycle that they're at, I'm happy to answer any questions.
It's a huge issue. And it's a huge issue for women before they even know it's an issue, I think. So we are going to really dive deep into all the hormone stuff, because that's been top of mind for anyone who's listening to the podcast. Those are all the questions that I get. We need more, we need more, we need more. So before we dive into that though, can you explain to people, because it blows my mind that not everyone knows what a naturopath is. And so can you explain how you are different?
Yeah. So naturopathic doctors, they are licensed physicians. So you have to actually go to a medical school. So not every state in the country has a naturopathic medical school. There are certain states that have one. For example, Arizona. It used to be called Southwest College of Naturopathic Medicine. Now it's known as Sonoran University. So it is a 4-year medical degree. In order to get into it, you do have to have an undergraduate degree and certain prerequisites. You have to have an interview. So the same formality of coming into a regular medical school. And that's kind of what it is. We call it medical school. You go in, you learn all the pharmacology, basic sciences, you do rotations, clinical work, pharmacology, prescription. But what's nice about our curriculum is they teach us all about botanical medicine, nutrition. I think standard medical conventional systems only teach you 8 hours. I think that's all that may be required. But ours is ingrained from the get-go, from that curriculum. And then in addition, they teach us acupuncture, physical medicine, all about nutrition and supplements and diets. And so as a student, you're learning all this information and you're integrating it from day one. So by the time you graduate, you'll know how to implement these. So you're not just coming out thinking of a systems treatment. You're thinking, what causes this? What is the original cause? So the principles of naturopathic medicine focus on treating the root cause, treating the body. The body can heal itself, kind of the basics, the most common sense things that you think. And we're not just focused on what's the symptom and here's the pharmacology for the symptom. Mm-hmm. And one big key difference is that if you want to be a surgeon, naturopathic medicine is not for you, because we don't come out and do surgery. So that's one thing that differentiates us. We can do minor surgeries, but not any surgery. So we're focused on keeping you out of the hospital.
Mm-hmm.
So,
but you also have a wide network of other doctors that you work with. So for instance, I just came from Dr. Desai's office earlier today, and that is someone who you had referred me to. She's a cardiologist. Yeah. And so it's exactly like going to a doctor who, if it's not in their area of expertise, you have your people that you refer to, your other doctors that you refer to.
Yeah, we collaborate. So we try to identify the problem, and then if we can recognize what it is, we try to present solutions that are natural and lifestyle focused. And, but if they require further intervention and they need pharmacology, we can. And some states you can prescribe. Arizona, we can prescribe, but certain things that they need further assessment, then I love collaborating with other doctors. I have a whole big network of cardiologists. In fact, just not cardiology, kind of a naturopathic run sometimes. So,
well, because cardiac health is also a huge issue for women.
Yes.
And that's something that you, as a patient, one of the first things you did was screened me and found I had this genetic marker called lipoprotein A. And you were like, oh, you should really go see you should go see a cardiac specialist. And I was like, I'm thinking like, I mean, because I was in my 40s, I'm like, I'm fine. And then both my parents ended up with open heart surgery. And I was like, oh, Dr. Khoshaba was totally right.
See, I always say it. So I'm always trying to like help my patient identify, like, picture yourself when you're 80 years old. What would your 80 years old self tell you to look back? And then it's these things. And they say that heart attack you had in your 80s started in your 20s. You know, the stroke that you had in your 70s started in your like 30s. So it's like, I always try to open up my patient's eyes saying it's not a problem now because genetic, these things are genetic and they're quiet and they're silent and they sneak up on you. And then you're like, where did this come from? Because a lot of these underlying cholesterol issues, sugar issues have no symptoms.
And that is scary because I have started seeing that with friends of mine.
Yeah.
Where they have gone for like a calcium test and find out they have blocked arteries. Like I had one friend who had to go have stents, but no, he had to have open heart surgery, but it wasn't open heart. They like went in, I don't know. Anyway, it was some version of open heart surgery where they didn't have to crack him open. They can go into the side, I think.
Mm-hmm.
Anyway, the point is, he's like my age and he looks great. You wouldn't look at him and think, oh, that's a couch potato carrying 200 extra pounds who's a heart attack waiting to happen. He looks like a fit guy.
Yes.
So,
and it just sneaks up. So we just can't stereotype people for the way they look on the outside because believe it or not, those people that come in that are overweight and they eat junk food all the time and they run their labs and I'm like, how are they normal? And then
it's like there was a commercial that they put out there a long time ago and it had one cholesterol number and it had a very big obese person and a really tiny thin person and they had the same cholesterol number. Do you remember that commercial?
I don't.
Yes. And so, and it's the same thing, we have friends and I have, mine's genetic, I have high blood pressure, the cholesterol thing. And so, and one of my friends, he's like, my texts look perfect. And I'm like, he goes, I don't look like it, but I am. I appreciate that. I try it every day and it just fails me. So
that leaves like watching what she eats, going to the gym. Right?
Yeah, you do all the things. And then those are those patients I feel, really like, okay, I got to figure out what else I can do because this is genetic. So sometimes it doesn't respond to all these lifestyles. So they have to be more on top of it and not ignore. So as a job as a naturopath, I always say, you're not just here for your thyroid. I can fix that. I can help you regulate that. But look at this bigger picture. Look at the silent killer. Look at the quiet things that you need to wake up and pay attention to.
The other thing I also appreciated because I started going to a naturopath because of my thyroid back in my 40s. It was a combination of my thyroid and I was exhausted and I thought it was my thyroid, but it was my testosterone was low. And so I went to a naturopath because I had been using, I think it's like levothyroxine, which is the typical
generic.
Just the generic. And I have a primary care physician. I love her too. But she has 15 minutes to see me. Now, I have a great relationship with their office too, but, she just, it's prescriptive. Here's the levothyroxine and your prescription's going up every year and that's how we're going to manage it, right? But the thing I loved about coming to see you was there really was an assessment of, okay, what if we get these supplements in place, like the black cumin seed oil, which brought my antibody, because when you have thyroid disease, it's just your antibodies are attacking your own thyroid. And we were able to bring, my levels were like undetectable. They were, or that you couldn't count them. They were so high, like they were off the charts.
Yeah, they were.
They were off the charts.
Yeah.
And we were able to bring them down. And anyway, so and when we have a conversation, it's this holistic, it's not just the thing in front of us.
Yes.
It's what else is going on, what supplements might be low.
Yes.
What,
treating the overall approach. So it's like taking we can fix the thyroid, but how are the adrenals doing? And I always say like the departments, I call the body like a department. What's going on in one department and how does that affect another department? And so
That
It's
sounds like
fun.
my
It's like a
office.
detective job, and it's kind of fun. I take like as a puzzle, and I try to help you kind of put your pieces together. Because sometimes, like you said, people think that it's their thyroid. I feel like this poor thyroid gets blamed for a lot of things. Everyone comes with my thyroid, my thyroid, my thyroid.
Yeah, because that's what we're trained. We're like, oh, you're getting, you're getting heavier, you're exhausted. Oh, it's your thyroid. And yes, that's a piece of it, but that's not the whole thing.
Yes.
And one of my favorite times when I came to see you recently is we've kind of been tracking the hormonal changes, and that just happens with women, right?
Yes.
Like it's just these hormonal changes that happen, and we've been tracking it. And I think that was right. I had bled for 13 days straight. I was utterly exhausted. I woke up. All I wanted to do was stay in bed. I couldn't function. And I had my levels drawn, and I came in to see you, and you sat down with me, and you're like, so welcome to menopause. Because it was all, she's like, so you need some estrogen, and we're going to fix it. Literally the estrogen overnight. And you thought it would take a bit.
Like this. Yeah.
My body was like, you're like, oh, that's good. So I love the process around the work that you do. So, I mean, I've had a whole experience with you, but what's going to be someone who comes to your practice? What is that experience like? Because if someone doesn't know what a naturopath is, I want them to understand, like, this is a doctor's visit. It's like, it's going to feel very similar, but it's going to be level.
Yes. So one thing, my number one expectation is they don't have white coat syndrome, because I feel like that's something that's really common in that typical medical setting. They get in there and they get afraid, and then they feel like on a time crunch, and the doctors are always running late. And I try to be on time as much as I can. Sometimes I give extra to people who need it, so I always give that time to anybody who needs it. So, but I do try to stick and to the time so I can give that patient all the allocated time. So a new patient to my office that's an hour. We have 1 hour to sit down and discuss what you're here for, what is bothering you. You may come in thinking it's one thing, but then I'll ask you questions on your history. And I kind of don't even want the AI. I think recently what's been happening is people coming in and Googling all their symptoms with AI, and then they're giving me the AI report. And I'm like, wait, no, you can't. I don't want to get distracted with that. You got to put that away.
Yep.
Give me the opportunity to think about it and help you put it together. Because if you show me everything that AI is doing, then, you're kind of taking us down this tunnel.
It's going to lead you that way. It's like if you're investigating a murder.
Yes.
Everything comes back to murder and glamour shots. She worked at glamour shots. Murder and glamour shots. But it's like a detective who's like, this is the suspect, and I'm gonna pin the case on the suspect, right?
Yes.
And you're like, I don't know. I don't even want to know who the suspect is.
Yes.
I want to go in blank slate.
Exactly. And that's what I want to happen. I think recently with more AI that we're seeing more and more of that, but I'm like, hold up on that. Don't even show me, but maybe down the road, if we're not getting where we want, then let's kind of look into that and use that as a tool. But anyway, not to digress on that topic, but it's more just like to expect us to sit there, discuss, think about the topic, and then the follow-up is where we get into the results. So the follow-up's about 45 minutes, and that's where we initiate treatment. So treatment can be like, what are you doing for your lifestyle? What diet should you particularly need? Do you need further testing? Are there other tests that this basic blood work doesn't capture? Do we have to do other tests to find out? Like if they tell me they're having GI problems, there's not a lot of blood tests that can help me rule in or rule out. So I'm going to say, you got to do a poop test. And then they look at me funny because
they're like, what? We are not that kind of office.
Take it and go.
But I think that's the critical piece, is that it's a completely different experience. The look of the office, the vibe of the office, but a full hour. And I mean, Kathleen, when have you ever sat with someone for 1 whole hour and just talked with them about everything that's going on in your life from a health perspective?
Yes, right.
And when you think about it is, what's the number, because we work in finance, right? Yes. So everyone says the number 2 thing that's the most important is finance, but the number 1 thing is always health.
It is. Like if you don't have your health, Like it's very scary and the unknown. You think you're fine. And it's just like when you get the flu, right? And you're out for a week, you're like, I'm never going to be the same. And then you get up and you're like, I appreciate feeling good, doing what we need to do, but it's just, so if there's a health scare.
Yeah. So
terrifying.
I always tell them, so when you have your health, you have a million problems. And then when you don't have your health, you only have one problem.
Yeah, that's true.
So health is number one.
It is.
That's a good one, Dr.
Yes.
Khoshaba.
Yes.
I like that.
And they say health is wealth, because I always say, because I'm a big Apple fan and I worked at Apple, and
Really?
Steve Jobs,
I didn't know that.
yeah, now look how successful he was and everything. And then like all of that. And in the end, like, he had pancreatic cancer,
Yeah.
And they caught it early. Like, didn't they catch it early? And he could have done some treatment, but he just opted to do, like, I don't know.
Yeah, I should have read the rest of this. I didn't even read the rest of the book, but I do admire him, and he's one of my favorite like role models, and just the whole, I model a lot of it around the patient experience. So it's all about, we have like an internal value system we call NES Care. So it's like, you have to like discuss everything with the patient. You empower them. You're partnering with them, and then you're like, with Apple, they always end with a fond farewell. So we want to sustain that relationship so that we are always helping you evolve for health. I've had patients, believe it or not, I've helped them, and then I don't see them for like 5 years, and 5 years later they're back in there. And so they're like, remember, you helped me with that, and now I was healthy, and now I have this other problem. Can you help me? So sometimes it's like getting them on track, especially when they first come in and they're really off. And then the goal of this is so that they don't keep coming. They don't have to keep coming to see me.
That's true.
That's the part. Well, and people talk about that all the time, right? How many times do people say we have a sickness system, not a health system, right?
Mm-hmm.
And I think that is the reason that you should go see a naturopath, is if you want to have a health system, if you want to have an experience based on health and all the components of health, because like you said, your body's all these different departments. And like, so if you're eating terribly, or you're smoking, or you're drinking too much, or like during my divorce, you did some labs on me and you're like, oh girl, your liver enzymes are a little high. And she's like, but you're stressed and you're probably drinking more than you normally do. I'm like, true statement, Dr. Khoshaba.
That's so funny. I was saying this yesterday, because we picked up an Uber to take us to the airport. And I think we should be able to choose smokeless Ubers. Like you can pick a non-smoking room. We should be able to pick a non-smoking Uber ride. Because like you just feel like you smell, and then you feel like you smell like smoke when you leave their car. And I don't know.
Okay, here's
Uber,
the trick. Here's the trick. Did you go alone to the airport?
No.
Okay, so whenever I go to the airport like alone, or I'm traveling alone, I always get an Uber Black, even if it's super expensive, because I just had a regular Uber one night, and it was the same thing, like smelled like smoke. The guy definitely was on drugs. And I was like, oh, this is really not safe. But I feel like if you get an Uber Black, they're usually professional drivers. Mm-hmm. And so my chance of getting killed are lower.
Lower there. Well, but the other part of that too. My husband's like, you just need to not rate him or rate him low. And I'm like, no, because then now he knows who we are, and then he's going to murder us.
See, it all comes back to that.
Oh my gosh, wait, can I segue for a second?
Yes.
This is hilarious. So, I grew up in Tacoma, Washington. It was just, you have to be aware of your surroundings. So I'm on my phone on speaker, walking down the hallway. And at this hallway, this hotel, they kind of have a lip. And you open your door, right? So it's not the door's not flat to the wall.
Okay.
There's a lip and there's a door. This man was standing there holding the door open, and I was walking and talking on the phone. And I just happened to look at him, and I go, ah! And he goes, ah! I scared him as much as he scared me.
Because you couldn't see him and he was holding the door. And then they're like, there's a person.
Yeah. So I'm like, my Peg Bundy walked to the elevator, and I'm waiting for him, and I see him coming, so I hold the door, and I go, man, you scared me. And so his wife came, and I go, I'm so sorry, I almost karate chopped your husband. And she started laughing, and I go, it's what you have to do in today's round. He goes, okay now, ma'am. Oh, that was so funny.
That was funny. That's hilarious.
Oh my God. Okay. Speaking of segueing, we didn't mention the name of your practice. So it's Natural Endocrinology Specialist. They're located in Scottsdale, Arizona, and it's Dr. Khoshaba. And you need to spell your last name because I put in like three.
I can spell it.
Wait, can I try?
Yeah.
Okay. Okay, hold on. Okay. Just give me a little like this or this.
Okay, you got
for
it.
each letter. So K
Mm-hmm.
O
H.
Khoshaba.
Yeah, now you got to say it the Middle Eastern way.
How do you say Khoshaba?
You have to get the phlegm going.
Oh, gosh. Khoshaba?
Khoshaba.
Khoshaba.
Khoshaba. Yeah.
I love
Pretty
it.
good, right?
Khoshaba.
So
love
one
that.
time I called the compounding pharmacy. I had to call in some topical testosterone for a patient. And the pharmacist is like, thank you, Dr. Khoshaba. And I was like, that's so weird. How do you know how to say my last name?
Yeah.
Like, he's like, because I'm a Syrian too. So, so he was, yeah.
You're like,
so I was
I love my people.
So I know.
You're like,
Can you rest up more?
Look it up.
Look your sister up.
So, my husband always say in America, it's not what you know, it's who you know sometimes. So, that's how it.
Is your husband Syrian?
Yeah, he's in finance. He works at Chase Bank as well.
Oh.
He does not know anything medical. Nothing.
He's like, as much as I like listening to you, I still don't know.
He's like, yeah.
Which is actually nice sometimes, right? So you can you don't have to talk shop. You can come home and you can listen to his problems and you don't have to fix them because you're probably like, that's your world.
Yeah.
I'll invent a way, but you're not going to tell him how to create a portfolio or, manage an asset allocation.
Yeah, I have no idea. And I'm like, open up an account. So, that's all I need.
Okay, so someone comes to your office.
Yeah.
It has this great vibe. They have this intake meeting. You're doing the follow-up consult meeting with them, or is that?
Yeah. So during the initial appointment, part of it is like assessing what they're struggling with, and then we order blood work. So what kind of blood work? We usually kind of do a comprehensive set of labs the first time. So we'll run like things like their blood cells, then their chemistry, and then their metabolic markers like their fasting glucose, liver enzymes, kidney function, and then I run all these hormones and see like it's not just a basic thyroid level, like it's not just TSH, it's free T3, free T4, the antibodies, sometimes reverse T3, and then adrenals, and then we're looking at that function and the ovaries and what are they producing, And we do see men, but majority we do see women.
I have a question for you. Are you able to tell from a blood test if someone might have cancer?
Not all the time.
Okay.
And, speaking of that, so like usually to find out, like, let's say liver cancer. So we always run a comprehensive metabolic panel. We call it CMP. In that panel, you get the liver, kidney, and, electrolyte levels. And I've had patients who have liver cancer and their liver enzymes are normal. And so you can't just base cancer off of like the CMP and liver enzyme tests. Now, actually, we have way more, speaking of specialty tests, there are companies out there, like, for example, the creators of Cologuard, Exact Science.
Oh, yeah.
I love that company.
Speaking of goods to go.
Yeah. But they're a blood test. They can run one blood test and they can kind of screen you for like cancers in like 21 organs. And it's detecting DNA, abnormal DNA. If it triggers positive, then we do follow-up because we think that there is some type of maybe cancer in the body. It's, yes. So we are able to kind of now do specific blood tests to test for cancer, but those markers don't necessarily show up on routine blood work.
Okay.
Well, that's so interesting because like pancreatic cancer, I feel like is such a silent cancer. My mom passed away from pancreatic cancer. We didn't know she was sick. We thought possibly she had diabetes because just some of her tests were coming back that way, and that's genetic in her family. We have everything genetically, except for we don't have lipoprotein.
That's the one thing you don't have.
My doctor, my cardiologist, he said, you've done the genetic testing, and that's about the only one you won. I was like, all right. So anyway, but so it's just such a silent cancer, and you would just think that they would have more things to be able to detect it sooner. And so it's interesting that
Is there anything to detect? Does that detect pancreatic
It can
cancer?
actually. These specialty cancer tests now are really good about detecting very really bad cancers now, because those cancers tend to have more methylated DNA that's abnormal, and they show up really quickly.
Mhm.
So we're able to detect the worst case cancers. It's actually easier to detect that than thyroid cancer, because thyroid is more localized.
Mhm.
It doesn't spread that methylated DNA, so it's harder to capture. Same with like prostate cancer, but definitely like liver cancer, pancreatic cancer, colorectal cancer. These things they may show up earlier in the blood test. So that's actually really promising that way.
That's fantastic. No, that,
Yeah.
and because I've always, because it's scary that we can test for so many things, but I feel like a lot of times cancer just is like, surprise.
Yes.
Yeah.
And so many cancers we don't have blood tests for. So like we have an ovarian cancer marker test, but it doesn't always mean you have ovarian cancer. It can be elevated in endometriosis or any other like gynecological issue. Colorectal cancer is just your blood test, but that could be also hit or miss. Pancreatic cancer, but there's not a lot of tests that we have to detect cancer.
I've also heard that that colon cancer has been on the rise in younger women.
Yes. They've actually changed the guidelines. So some of the guidelines used to say we have to screen 50 and up, colonoscopy 50 and up. They've changed it to 40 because we're missing this decade worth of patients. So now it's like 40 years old. You don't even question it. And you know what? One interesting fact is I had a patient yesterday and she's 30 years old. She has really, really bad anemia. So anemia shows up on blood tests when their red blood cells are low, hemoglobin, hematocrit are low, and then there's a marker called ferritin. So often we assume, oh, she's menstruating. It's typical for girls to have anemia. We can replace it. But actually, you have to say, if they have anemia, it's colon cancer until proven otherwise.
Oh,
You have to prove
Really?
it's not colon cancer and then move along. Because I could treat her and replace her. But what if there is this underlying, you don't want to mask it. So I'm like, before I keep topping it off and adding more iron in
Or putting the Band-Aid on.
Yes.
Before I keep Band-Aiding
Rule
over
it out.
and then all of a sudden-
Absolutely. You don't want to. It's a pain in the ass.
More
You
food.
gotta go do it.
You gotta do it. You gotta do it.
Go see a GI doctor.
Okay, let's go back. Let's talk about hormones, because
Okay.
that's what we get. That is, I feel like you are, I feel like you have a magic touch around hormones, because when you get back a panel of my blood work, it's many pages long, small font, lots of little numbers,
Yes.
and you really are deciphering how they are all interconnected. So tell me how the magic works.
It's like a report card, to be honest. So I always try to look at it as a report card. And one of my favorite moments is when a woman is menstruating. I predict the date of her last menstrual period.
She can do that. She's like, yes, she can do.
Amazing.
She can do that.
So and they're like, how'd you do that? Because when you understand the cycle and you understand when the hormones are doing what they need to be doing at that certain time of the cycle, then it's easy. And then you know that they're in sync, that I feel like, yes, your hormones are on track. But if I guess and they're completely wrong, then I know that there's something wrong. So we have to go dig deeper. And then it requires us testing hormones on certain days. So, for example, if I'm trying to assess if she's truly perimenopausal, like how close are you going to get to, menopause?
Mhm.
Then I have her test on day 2. I test FSH and estradiol levels. If I see FSH levels starting to climb crazy day 2, then I think that, the pituitary is yelling at that ovary, hey, shouldn't be yelling that much on day 2. So
It should be just like a stern voice.
Exactly. Just like
not
a
like
signal.
hysterical.
Yes.
Just a stern warning.
Yes.
It's like, girl, get it going.
Get it going. Yeah.
Gotcha.
So, small signal. But then, and then on day 21, if she's having maybe issues with progesterone, we assess progesterone day 21, because that's where it peaks. That's the top of the curve. So if it's under, there may be a luteal phase, defect that could cause shortening periods, and then hot flash, and a lot of mood swings, irritability, anxiety tends to show up there. So,
Is that where you start getting that flat feeling, or is it, does that, no? Because sometimes there's I remember when I was going through the beginning of menopause or whatnot, you just are like, I'm not excited. But when I started, I think it was estradiol I started first, I was like, Like,
You were like, it's like,
Yeah.
this is fun.
Yeah.
Life is good. Life is good.
Yeah. So it is. It depends. And like sometimes you would think that some women, for them, low estrogen could show up as depression, and some women could feel more irritable. So it's hard because it's not like one symptom is the like textbook, and that's what drives us. Sometimes, I believe it or not, I've had patients in there presenting like they're hypothyroid, like they're so tired and they're fatigued, they're gaining weight, the classic. But then I run their labs, I'm like, oh my gosh, they're hyperthyroid, and they would never believe me if I tell them they're hyper. So sometimes these symptoms, and I always say sometimes the symptoms of the extreme look identical.
Interesting.
So, yeah. And so sometimes you just have to, that's why we have to run blood work. There's so many women who come in, like, I've never had my labs done. My doctor's just giving me hormones. I'm like, well,
that's
how do
kind
you
of
know where to
crazy.
go?
Yeah, that's like taking a road trip with no map.
Yes.
Like, how do you know where you're supposed to be going?
High, low, just subjective. And I think subjective is like, it's good to hear those. But you got to be objective too and have something to kind of track in that,
When do women generally start experiencing perimenopause?
Yeah.
And I know that's a wide range too, because some women, like, it's in their 20s, right? And but besides the outliers, like when does that generally?
When do they start? Okay, so in America, usually 52 is typically the average age they hit menopause. So what's perimenopause? It's the years preceding the actual menopause. So the definition of menopause is 1 year cessation, no menses, no period for 1 month, for 1 year, 12 months. But on blood work, you can see it. And I can see if they hit menopause because their FSH from their pituitary is yelling. It's way over 25. And we used to be able to count 2 numbers. Then we can just count 1 number, elevated FSH, and then estrogen will be really low. But perimenopause occurs sometimes as early as in the early 30s, sometimes 40s. And women will spend a third of their life in like at least perimenopause to menopause, a third of your life. And so that's a long time. And so you start to, after 30, hormones start to decline little by little. I always say, like, usually like progesterone might show up a little lower, and then the adrenal glands a little lower. And I think the last thing to like finally go away is estrogen. And that's what we've just identified as menopause. Like you don't have estrogen, and then you're having the hot flash and the night sweats show up even more. But it could be a decade before you actually hit that.
Because I hit in about I think right around 40. So you could easily be 10, 15 years in perimenopause where nothing's on fire necessarily, but you're slowly getting off your game and things are slowing down. And then by the time you get to menopause, it feels like, for me at least, I felt like I hit a wall. Like last October when I was bleeding and I was exhausted, I'm like, what is wrong with me?
Yeah, it can be intense. So like usually there's this transition, right? And so we call it premenopause. Usually I'll say premenopause is around 40, 41, 42, up to 45. Once I get to 45, I'll say, okay, you could be more likely to be perimenopausal. And the 2 years that precede menopause, so let's say 52 is this magic age, but sometimes it happens earlier. But let's say 52, between 50 and 52, that's where the roller coaster gets really crazy. I don't know if you remember, but like estrogen levels can go through the charts. So then they'll be like looking like pregnancy levels, first trimester. They could get to 500, 700. And you're like, whoa, why are they at like a 700? I feel like it's the ovary is just like giving its last hurrah. It shuts down.
I am not dead yet.
Yeah.
I is not dead. Dude, help me out.
And then after like a month later, 2 months later, you see that crash. And then you're like, wow. But I always check for sure, make sure progesterone is not high, because then it could be pregnancy, right?
Oh my God.
That's
that's worse than menopause.
Yes.
I mean, just like someone was talking about someone was trying to get pregnant. I don't know, maybe Pear was telling us someone was trying to get pregnant. I'm like, he is 70.
Yes.
I'm like, he's 70 and his child will be 88 when the child goes to college. Come on.
I know, if she makes it to 88. Right?
Well, yeah, that's the thing.
It's so crazy. Yeah.
I mean, so I had a friend, she's coming in next weekend. We're going to miss each other, but she was married younger, thought that was the man of her dreams, wasn't the man of her dreams. The marriage fell apart. She was single for a hot minute, met a younger guy, thought it was just, like getting her groove back. Well, she married him. He's 9 years younger than her. He's Persian. Anyway. And she's like blonde. Like, yeah.
They love the blonde.
So, yeah. Yeah. Yes, they do. Well, and they do. So anyway, but they made this beautiful baby. She got pregnant on purpose at 47. I was like, oh dear God. And then probably 4 months into the pregnancy, she posted a picture of a puppy on Instagram. So I called a mutual friend. I said, did Melissa lose the baby? Because I'm thinking the only way at 47, if you are pregnant for the first and only time that you would then also throw a puppy into the mix,
Right.
is if you have lost the child.
Yeah.
And then Melissa called me and was like, no, baby's great, but we signed up for a puppy during COVID and it came. So now we got a baby and a puppy. So here you go. Anyway, but
and how is she doing now?
She's great.
Yeah.
And their son is, he is gorgeous. He models.
Yes,
he is a gorgeous baby. Yeah. And she loves it. There are benefits on both ends. Right? Universe, I do not want to get pregnant. And I'm in menopause anyway. That should be said. So when I'm in menopause, can I just not get pregnant?
So when you're technically menopausal, your FSH is so high and you're not making estrogen. So the likelihood of that is probably less than 1%.
Oh.
Right. So
I'm keeping that. I'm keeping the IUD in because you said there's a chance. So you said that what I heard was there's a chance. So I am not. I'll be 80 years old and be like, I need another IUD. I'm not going to chance it.
You never know. You never know, right? Yeah.
I think it's that the whole perimenopause or menopause. You just go through life. For me anyway, just go doing the things you need to do. It's family, it's work, it's taking care of yourself, and then you get hit with that, and you're just like, what do I need to do? And so I saw my OB, and she was like, we're going to do labs. And, part of my genetic issues is that I was still on estrogen birth control, my 40s. Right. And she's like, you cannot be on this. This is why your blood pressure is so ridiculously high. And so, anyway, it's just fun to see your lab works and what you've done and where your body's going. And, is it fun? Not really. But so we did that.
It is interesting. Yeah. It's interesting. Yeah. You're right.
It's just me. And then to start it on the testosterone, that was a game changer. I think that I needed the hot flashes to go away. That, it's just not fun at all. And I still run hot, even though, I'm on patch. And we had office masseuse in for after tax day for everybody. And she's like, you run real warm. I'm like, at least I'm not sweating.
And I run cold. I'm not 98.6. I'm always 97 point something.
Oh.
Isn't that weird?
A little bit. So it could be typical more with hypothyroidism too. Yeah. So we often see your thermostat needs a little.
I just always need a sweater. I just always need a little sweater or something. Thank you.
I just feel warm all the time. And I used to be freezing cold all the time. All the time.
Interesting. Yeah.
So what do you see with your patients that you're like, this is something that typically happens and it's kind of things that need to be watched or corrected or we could do a better job of? Right. Or is there anything?
That I think of. So for example, one of my biggest concerns is their bone density. So this is something you don't think about when you're 40 and 50. You don't think about your bones. But I always say, as soon as you enter menopause, within that first 5 years, you could lose up to 20% of your bone density.
Oh, no.
That's a lot. And so we can't really get your bone back, I know there's medications to slow your bones from,
well, this is not Harry Potter. We are not regrowing skeletons, people. Yeah. We are not regrowing skeletons. There's no Skelegrow. It's not a Harry Potter book.
So we just want to maintain it. Why should you allow your body to lose that 20%? So it's changing that trajectory. So I always say initially, before we even start HRT, let's get a baseline mammogram. Let's get other breast imaging. Some women, we do breast ultrasounds, MRIs, and then we also do baseline bone density scan. So I kind of see where they are before we are on this journey. And then every 2 years, I'll be monitoring their bone density and making sure they are staying on top of it. Because I've had women, and I've been doing this now for 15 years. So initially, when I first started, we did HRT, and then there was a lot of women who did it for like 5 years, and they're like, okay, I'm stopping because I'm scared. I just don't want anymore. I'm like, now on maybe they started at 50 and 55, 57. They're like, I'm done. And I still see those women today because they stopped it. And now they're like 67. And guess what? Their bone density is really just tanked. And they have osteoporosis, some of them.
Oh.
And I look back and I'm like, oh, I wish I shoulda, coulda, woulda.
Yeah.
Continued the HRT. But at that time, with the information that we had, we were just trying to make the best decision. But now looking back, I'm like, oh, I wish we would have continued. Some women did continue, but the woman who didn't, I wish they kind of would have.
But that's like in our practice, like, as a financial advisor, when I first started out, I had a process, and I did not make people fill out budgets before they retired. And now people hate filling out budgets, and I get it, but I make people fill out budgets before retirement, because this theoretical, what you're going to live on in retirement, you need to actually make sure that's what you're living on before you retire.
Yes.
So it's one of those things, like I have this couple that I worked with, and they had a bad experience because they're like, oh, we're good budgets, we're good savers, we're going to be able to live on this amount. And that is not what happened. And they got sideways, and then I had to backtrack with the budget. You can put a budget in place. So you can't regrow bones, but you can put a budget in place.
Yeah.
But it's the same kind of theory of you're perfecting your process, and now it's a standard part of the process.
Right. So it's like putting it now they took off some of the warnings. If they took away the warnings on, the hormone patches back in November. So the warnings used to say it could cause cancer, it could cause dementia, it could cause cardiovascular disease. I'm like, we've known for all this time that they actually help. They don't cause, generally cause
they do.
those.
Yes.
They help protect you against those things.
Can you talk a little bit? And I don't know. So I remember back in the 90s, there was a research report that was done, and it chilled the entire utilization of hormone replacement.
The Women's Health Initiative. Yeah.
And so do you know, I'm
familiar with it. So the Women's Health Initiative, they based it on mostly postmenopausal women receiving hormone therapy called, made from horse's urine. It's synthetic, even though it's natural. Horse's urine, Premarin. And so they're using it in these postmenopausal women over 65, and it's synthetic and not even using maybe progesterone. So therefore, yes, there's way more risks associated. But now what we do is that if a woman has an intact uterus, we have to give estrogen with progesterone replacement. The estrogen that we use now is more bioidentical, so meaning it's bioidentical to a woman's ovary, even though, yes, necessarily it's not coming from an animal source. It's bioidentical equivalent. So the risk is like, it's just like the body's, we're just kind of replacing it, just like we're replacing thyroid hormone or replacing estrogen, right?
Mm-hmm.
So
and it does have a different effect if you start out with it and from perimenopause, and as opposed to you had nothing, and now we're throwing everything at
you. Right. So I always say, like, when you're transitioning from perimenopause to menopause, your body knows how to utilize estrogen. It's used to it. But 10 years you don't use it, then those receptors that you have are downregulated. And then you put the hormone in, and then the body's like, what do you want me to do with this? I don't have any. It's like I always use the analogy, baseballs and not enough gloves. It won't work.
That's exactly right. So, okay. So hormones, the bone density, how long do women typically stay on hormone replacement? Is it like indefinite?
So that's always the question. It's always like, how long? It's always personalized. So unless they are having problems with it, and we have to discontinue. Some women, with estrogen, the warning that still remains on it is that it could cause endometrial thickening, and their lining can get thick. And so sometimes that lining is getting too thick, and then they end up developing, they have to get that biopsied, or sometimes they've had a fibroid and they went into menopause and that fibroid just kind of shrunk. And then you add the hormone and boom, that you're waking up that bear and that fibroid starts to get bigger. And so there are times that you have to adjust and course correct. But if they, we just individualize, it's all individual. And and so we just and if that's not an option, we have to discuss, what other hormones, if there are options for them, sometimes it could just be progesterone or testosterone or DHEA. And the mother, do you know who the mother of all the hormones are? The mother.
Who? What? Who? What? What's her name? What's her name? Tell me. Tell me.
It's pregnenolone.
Oh, pregnenolone.
What is mother?
Who is that?
So that is the number one hormone derived from cholesterol to start the whole hormonal cascade. So it makes pregnenolone, and that converts into this progesterone pathway, and then there's this DHEA pathway.
And that's why when my cholesterol got too low, you were like, you have to back off.
Exactly.
Yes.
Because you can't. The mother, hormones are made out of fat. The mother is cholesterol. So if you are, taking meds that are really suppressing your cholesterol, then you may be suppressing the fuel to make hormones, right? So we have to be careful with all of that.
It's all balance.
Yeah, it's a balance, right? You can't have too much and too little.
Every department has to be doing its job.
Yes,
exactly.
Do your job.
Do
your job. Okay, so there are naturopaths in other states, but if you're in the Scottsdale area, natural endocrinology specialist is. I can personally attest to it's just it's a wonderful, wonderful practice.
Thank you.
And everyone, it's like from the person at the front desk to the woman who draws my blood to you to
thank you. Yeah,
the folks that you come, that are you teach
my students and the residents, because I do take pride in it. Being Middle Eastern, number one thing we learn is being very hospitable. So my office is like my house. So who's ever coming into my practice is like coming into my house. So I have to make sure you're extremely well taken care of. And you know me, I'm always feeding people.
She is.
Take this, eat this. After a blood draw, make sure you eat. Make sure that they eat.
There's snacks everywhere. It's just like, you have to go to our office sometime, because literally we designed our office, who's the financial advising office. I'm like, it needs to look like a house or a room in my house.
Right. Yeah.
And it doesn't look exactly like a room in my house, but it's not your typical.
Warm,
right. It's warm, and we have snacks. So if someone is in another state, where can they go to find a naturopath in their area?
Okay, so if they're looking for somebody like who does what I do, endocrinology, I'm on the endocrinology board, so it's endoamp.com and endoamp.org, and you can go in there and search for a doctor if you're looking for more of like a naturopathic doctor who's board certified in endocrinology. So there are naturopathic doctors that are practicing just general naturopathic medicine. What distinguishes us from them in a way is that I'm board certified in naturopathic endocrinology. So that's primarily my specialization. So if you're looking for a doctor who does that, endoamp.org, or if you're just looking for general naturopathy, you can just search on AANP. It's American Association of Naturopathic Physicians. You could do a doctor search and find somebody in your area.
I love that. Yeah. And just ask your friends.
Yes.
Networking is the best.
Yes.
So you are amazing. Thank you for coming down and doing this.
Okay,
before we leave, though, we're going to do one good thing.
Yes.
So I'm going to let you start, because I think you know one good thing.
Yes. And I had, so this is kind of like what I love doing. So it's like, I want to help everybody, but there are certain patients that I can't really help. So for example, I had a lady who came out of Quartzy, Arizona. I mean, that's like near Yuma. Like I've never met anybody from there. It's such a small town, right? So they find me from there, and then they came all the way to Scottsdale. And this lady had a very massive goiter. So a goiter is a huge growth on her thyroid. And I asked her, like, what do you think has caused this, or what is this diagnosis? Have you been diagnosed with anything? She said, no, the doctor said I'm normal. I'm like, this is not normal. So I had her do an ultrasound, and it showed that inside the thyroid gland, her left lobe, she has a 72 millimeter nodule. That's the size of a nectarine.
Wow.
It's massive. I've only seen this a few times. Like, it does happen, but I'm not a thyroid surgeon, but I do know a few of my colleagues who are my friends. So that's the beauty of it, is that I have my friends that are, thyroid surgeons. So I try to connect them. And when the patient, I referred her to her, she couldn't get in till October. And I was like, oh no, like we gotta do something now. So I personally text her and say, you gotta get this lady in, please, like do whatever, and then she texted me back today. She's like, don't worry, we're going to get her in next week. And so that's a massive win. Because this lady, you can imagine, if you could just imagine if you had range, you can't swallow, you can't eat.
Yeah.
She has severe iron deficiency anemia right now. She had an alert level on her iron being so low because she's only, she's like pureeing things and drinking broth and soup, and and she can't swallow. And
the doctor, that's the other.
So
the other thing is that if you are a woman and you feel like something is not right with you, and your doctor is saying it's normal, trust yourself and go find another doctor.
Yes.
Because women there's a reason. It's hysteria comes from hysterectomy. It's about it's because women if you're a woman, you're supposed to be crazy. So we get discounted, and don't let yourself get discounted.
Right. Absolutely. So,
all right. What's your one good thing, Kathleen?
For me, it's always fun to go to, I'm drinking the Kool-Aid, but you go into the corporate office and you get to hear all about the bells and whistles and everything that's coming out. So the one good thing is that they're really rolling out some great AI tools that we desperately need and to be able to implement that. So I'll be counting down the days and emailing all of them when we're not seeing it go live.
You're like, hello.
Love it.
My one good thing is Sam, my youngest, is home, and he had a successful first year, and that's huge. Anyone who has a kid first year in college, it's a hard year for not just for academics, just for everything.
Like he breezed right through it, though.
He did. He's a rock star.
Yeah.
So anyway, all right. Well, I love you for coming.
Yeah.
Thank you. And we usually have drinks, and
we have our chai.
We have this. And we do cheers and press and hold.